like to give you a brief update on what is new on the ESC-EAS dyslipidemia guidelines. Since the publication of the 2019 guidelines, several randomized controlled trials have been published, and in light of the new data, some recommendations in the guideline have been updated. Previous recommendations that have not changed are still valid and are not mentioned in this brief update. Here you see the publication and the names of the task force that were involved in revising the guidelines. First of all, the risk assessment system has changed, and SCORE2 is a new model to estimate 10-year risk of cardiovascular disease in Europe. It has been updated to use contemporary data. It estimates 10-year risk of total cardiovascular events, and it's available for 4 different European regions. Here you see the new SCORE2 risk charts, and as you can see here, total cholesterol has been replaced with non-HDL cholesterol, whereas the other parameters are similar to the previous guideline. So the new recommendation is that SCORE2 is recommended in apparently healthy people below 70 years of age without established atherosclerotic cardiovascular disease, diabetes, chronic kidney disease, genetic or rare lipid or blood pressure disorders for the estimation of 10-year fatal and non-fatal risk. And for those over the age of 70, SCORE-OP is available. These are both Class 1 recommendations. The presence of subclinical coronary atherosclerosis by imaging or increased calcium score by CT should be considered as a risk modifier. This was not present in the previous guideline, but we know now that CT can reclassify risk, therefore it's a Class 2A recommendation. And risk modifiers should be considered in individuals at moderate risk or individuals around treatment decision thresholds to improve risk classification. Here you see the list of risk modifiers and family history of early cardiovascular disease, being from a high-risk ethnicity, stress or psychosocial stressors, social deprivation, obesity and physical inactivity, chronic immunoinflammatory diseases, major psychiatric disorders, female-specific risk factors such as early menopause, preeclampsia or other hypertensive disorders of pregnancy, HIV infection and sleep apnea are all risk modifiers. In addition, biomarkers such as persistently elevated high-sensitivity CRP above 2 mg/liter and elevated Lp(a) are also risk modifiers. Here you see treatment goals for LDL across categories of total cardiovascular risk. As you can see here, they have not changed, and the level of risk determines the intensity of the treatment. The extreme risk group for patients with recurrent events or polyvascular disease has been added to the risk chart now, and as a Class 2B recommendation, the LDL goal here is to go below 40 milligrams per deciliter or 1 millimole per liter. In primary prevention, there are some new recommendations that have been clarified compared to the previous guideline. And in primary prevention, pharmacological LDL-lowering therapy is recommended now in patients at high and very high risk that have high LDL cholesterol levels. But in addition, it should also be considered as a measure in patients with high LDL, regardless of the risk level, taking into account lifetime accumulation of LDL cholesterol and lifetime risk. There have been new trials with new pharmacological agents to lower LDL cholesterol. Clear Outcomes was a trial in very high risk patients unable or unwilling to take statins with bempedoic acid monotherapy versus placebo, showing significant decrease in LDL cholesterol and cardiovascular events. The ELLIPSE trial looked at patients with homozygous familial hypercholesterolemia using evinacumab, which is a monoclonal antibody against ANGPTL3, in patients already undergoing apheresis or taking lipid-lowering drugs, showing significant LDL lowering without major safety issues. So these have now been incorporated in the new guideline. Non-statin therapies with proven cardiovascular benefit taken alone or in combination are recommended in patients who are unable to take statin therapy to lower LDL levels. The choice should be based on the magnitude of additional LDL lowering needed. This is a Class 1A recommendation. As a Class 1B recommendation, bempedoic acid is recommended in patients who are unable to take statins to achieve LDL goal. And bempedoic acid can be added to the maximally tolerated dose of statin with or without ezetimibe. It should be considered in patients at high or very high risk to get to the goal. And evinacumab should be considered in patients with homozygous familial hypercholesterolemia over the age of 5 years who are not at LDL goal despite receiving maximum dose of lipid-lowering therapy. Here you see the average reduction in LDL levels with different pharmacological therapies with proven cardiovascular benefit. And as you can see here, it is possible to get an 85% reduction in LDL cholesterol with combination therapy. There are new recommendations for patients with acute coronary syndromes. These patients have a very high risk of recurrent events, and a stepwise approach will delay optimal LDL lowering. Imaging studies show acute and intensive LDL reduction improves the vulnerable plaque composition, and the observational trials shows that timing of reaching and duration of staying at goal matters. The new recommendation is that intensification of lipid-lowering therapy during the index ACS hospitalization recommended for patients who are on any lipid-lowering therapy before admission in order to further lower LDL levels. This is a Class 1C recommendation. And initiating combination therapy with high-intensity statin plus ezetimibe during index hospitalization for ACS should be considered in patients who were treatment naive and are not expected to achieve the LDL goals recommended in the guidelines with statins alone. And this is a Class 2AB recommendation. There has been a renewed interest in Lp(a) with specific therapies being developed. Epidemiology and genetics suggest a continuous relationship between Lp(a) levels and atherosclerotic cardiovascular disease and aortic stenosis. Caucasians have a skewed distribution of Lp(a) levels, as you can see here, and 20% of patients are thought to have Lp(a) levels above 50 milligrams per deciliter. And risk may be underestimated if Lp(a) is not considered. Below 30 milligrams, the risk is low, but above 50 increases significantly. And in the gray zone, the patient's other risk factors should be taken into consideration when determining risk in addition to Lp(a). So the new recommendation is that Lp(a) levels above 50 milligrams per deciliter, which is about 105 nanomole per liter, should be considered in all adults as a cardiovascular risk-enhancing factor, with higher Lp(a) levels associated with a greater increase in risk. This is a Class 2AB recommendation. Recommendations for drug treatment of patients with hypertriglyceridemia have also been revised in light of the failure of the prominent trial with pemafibrate and the strength trial with EPA-DHA combination. High-dose icosapent ethyl, as shown in the REDUCE-IT trial, should be considered in combination with a statin in high or very high-risk patients with elevated triglycerides to reduce the risk of CV events. This is a Class 2A recommendation. And volanesorsen should be considered in patients with severe hypertriglyceridemia due to familial chylomicronemia syndrome to lower triglyceride levels, but also to reduce the risk of pancreatitis in light of new trials and meta-analysis. People with HIV infection have a twofold increase in risk of atherosclerotic cardiovascular disease. And the REPRIEVE trial has shown some benefit with statins in these patients. So statin therapy is recommended for people in primary prevention aged above 40 years with HIV, irrespective of estimated risk and LDL levels, to reduce the risk of cardiovascular events. The choice of statin should be based on potential drug interactions. There are also new recommendations for statin therapy in patients receiving cancer therapy. Anthracyclines cause cardiomyocyte damage due to increased oxidative stress, and there have been 4 randomized controlled trials since 2019. As a result, the new recommendation is that statins should be considered in adult patients at high or very high risk of developing chemotherapy-related cardiovascular toxicity to reduce the risk of anthracycline-induced cardiac dysfunction. This is a Class 2A Level B recommendation. And finally, a new recommendation is that dietary supplements or vitamins without documented safety and significant LDL lowering efficacy are not recommended to lower the risk of atherosclerotic cardiovascular disease. Thank you for your attention.